Today in this lecture, we will talk about the regulation of internal potassium distribution and factors that can alter potassium distribution between intracellular and extracellular fluid. As we have started a new chapter about the regulation of renal regulation of potassium, calcium, phosphate, and magnesium. So our second topic in the new chapter is about the regulation of internal potassium and factors that can alter that distribution. We know that the value of potassium in the serum, in the plasma or the extracellular fluid is around 4.2, and there is around 14 liters of fluid in the extracellular space, and which leads to around total of 59 milliequivalent of potassium in the extracellular space. And similarly, we have around 140 milliequivalent of potassium distributed in 28 liters of fluid in the intracellular space, which leads to around total of 3920 milliequivalent of potassium in the body. So this is the whole potassium in the extracellular, and this is in the intracellular. But the body, with the help of the kidneys, will try to regulate the potassium level. We have discussed in our last lecture, in our previous lecture, that a slight deviation above and below the normal potassium level can lead to a dangerous complication like 3 to 4 milliequivalent above the normal potassium level can even lead to ventricular fibrillation or cardiac arrest. So normally what happens is that when we take a meal which is rich in fruits and vegetables, it gives us around 40 milliequivalent of potassium, and this leads to a change of around 2.9 milliequivalent per liter of change in the extracellular space potassium. 2.9 change. Now a 2.9 milliequivalent change in the extracellular potassium can lead to cardiac arrest, arrhythmias, dangerous arrhythmias. So the body has to adjust and redistribute it very quickly. So what happens is most of this potassium will go into the intracellular space, and when there is deficiency of potassium in the extracellular space, then the cells in the that makes the intracellular space, they would release the potassium in the extracellular space. So if we assume that normally there is a 100 milliequivalent consumption of potassium per day, and it goes into the body. What happens is that normally around 92 milliequivalent of this potassium is excreted in the urine, and around 8 milliequivalent goes in the feces. So that's why we are very concerned about the renal regulation, the regulation of potassium with the help of kidneys. So that's one important thing here. Around 92 milliequivalent per day out of those the average 100 milliequivalent that we consume, which may vary from 50 to 200, but this is the average. Now let's come to the factors that may alter this distribution of potassium. We will quickly go through these factors. So the first factor is insulin, the second is aldosterone, third is beta-adrenergic stimulation, then metabolic acidosis, then cell lysis, then exercise, and osmolarity. So all these factors can influence the distribution of potassium between the intracellular and extracellular fluid. Normally this distribution is maintained because when we consume a lot of potassium, this extra potassium goes into intracellular space, and then it is slowly released into the extracellular space, because the kidneys at the same time are getting rid of the extra potassium, and with the help of this redistribution, the normal levels of potassium in the extracellular and intracellular space is maintained. But it can be disturbed with the help of insulin, because insulin, it stimulates the sodium potassium ATPase, and it transports potassium into the cell. It transports potassium from the extracellular space into the intracellular space. Now people deficient in insulin has high potassium after meal. It is very important because insulin is, now we see that people who are admitted with a DKA, diabetic ketoacidosis, and we are injecting them with insulin, we normally give them extra potassium as well, because we know that potassium shifts the insulin shifts the potassium from the extracellular space into the intracellular space, which leads to hypokalemia. So it is important to give them extra potassium so that the normal limits are not disturbed. Another important thing is aldosterone, because aldosterone, potassium stimulates aldosterone. We see potassium stimulates aldosterone, and if there is a lot of aldosterone, as in Cohen syndrome, then there is decreased potassium level. And if there is decreased aldosterone, as in Addison's disease, then it leads to increased potassium. So the relationship between the aldosterone and the potassium is sort of reverse. Aldosterone will decrease potassium, and if there is high aldosterone in the body, as in Cohen syndrome, then there will be decreased potassium in the blood, hypokalemia. And in Addison's disease, where decreased aldosterone in the body, it will have high potassium level or hyperkalemia. But the release of aldosterone is somewhat dependent upon potassium as well, because this potassium can stimulate the release of aldosterone. Now another important thing is beta-adrenergic stimulation. Now beta-adrenergic stimulation, the beta-adrenergics like epinephrine, so they basically stimulate the potassium from the extracellular space into the intracellular space by beta stimulation. The beta receptors are activated, beta receptors are activated, and with the help of epinephrine, potassium goes from extracellular space into the intracellular space. If the beta receptors are blocked with the help of some drugs, like for example propranolol, then there is a slight tendency for towards high potassium in the blood, because potassium cannot shift from the extracellular space into the intracellular space with the help of beta receptors. So beta adrenergic stimulation, it shifts the potassium from the extracellular space into the intracellular space, and beta blockers, they will stop that. Now, insulin, aldosterone, and beta adrenergic stimulation can affect the potassium distribution. So can metabolic acidosis. Metabolic acidosis is when the pH of this plasma falls below 7.35, and this thing will decrease intracellular potassium. But if there is cell lysis occurs in a lot of conditions, like for example chemotherapy or in some malignancies. If this cell lysis occur, the potassium inside the cells will go out, and it will lead to increased extracellular space potassium. Then exercise can also lead to increased extracellular space potassium for some times, and some limited amount increase. And finally, if there is increased extracellular fluid osmolarity, then the osmotic flow of water and potassium to extracellular space. What it means is that if the extracellular space osmolarity increases, then there is movement of water from the intracellular space toward the extracellular space, and this movement of water will bring potassium along with water. So it will lead to increase in potassium level. So insulin, aldosterone, beta adrenergic stimulation, metabolic acidosis, cell lysis, exercise, and osmolarity all can affect the distribution of intracellular and extracellular space potassium, but which normally is kept in tight levels by the human body and the organs, especially the kidneys, because here we see that the most important thing in excreting the extra potassium is the kidneys. So they play a very important role. That's all about the distributions and the factor that can alter the distribution of potassium. Thanks a lot for watching the video.